Assalamu alaikum everyone. I hope you're all doing great. My name is Mohamad Behairy. I am a third year medical student, and today, inshallah, I'll be giving you a lecture on all the embryology of the cardiovascular pulmonary block. طبعا I like to start my past sessions with some words of reassurance. I just want to say no, embryology is genuinely so easy. 7 lectures, they might seem scary, they might seem like they're distracting you from the other more important lectures, but trust me, they are free marks, easy grades. Wallah al-Azim, in this PAL session, I covered everything you need, if you guys see, in 60 slides. All 7 lectures, everything you need to know in 60 slides. If you study this for your final, I can guarantee, inshallah, you'll get every single embryology question correct. Let's not waste more time. Well, let's get into it. We're going to start by talking about the embryology of the heart. طيب, first of all, let's go all the way back to foundation. تمام. We know إن we have 3 germ layers, the ectoderm, the mesoderm, and the endoderm. Which of these layers is concerned with the heart, which is an organ? It's going to be the mesoderm, تمام? Because the ectoderm is usually related to the skin and these nervous systems, the outside exoskeleton, while the endoderm is for the inner organs, the lining of the organs such as the lungs, the esophagus, and stuff like this. For organs such as the heart will arise from the mesoderm. But the thing is, the mesoderm itself has different classifications. These classifications are paraxial mesoderm, extraembryonic, and lateral plate. But the thing is, I don't want you guys to remember the divisions of the mesoderm. I just want you to know that the lateral plate is the one that will give us the heart. So if you get a question that says, which of the following germ layers gives us the heart or the heart tube, you're going to answer with lateral mesoderm. Tamam? Now, the lateral mesoderm, كمان, it has 2 divisions. It might seem complicated at first, but I'll explain to you why we need these two divisions first. You guys know in our bodies there are so many organs. Some of them we can feel them. We can feel when someone touches them or hurts them or any kind of sensation. Some organs, they exist in our bodies, we literally can't feel them. One of them is your heart. You don't really control your heart beating. You don't really feel your heart. It doesn't get tired or painful or any of that. And that's why we have these 2 classifications of the mesoderm, because the mesoderm will either give us organs that have these sensations, and we call them somatic organs. So somatic lateral mesoderm, or it's going to be organs that you don't feel, ما عندهم sensations, and we call those the splanchnic organs. So the splanchnic mesoderm. So let's start from the beginning. The mesoderm, we have the lateral plate mesoderm. The lateral mesoderm is what gives us the heart. But then this lateral mesoderm will have a somatic branch and a splanchnic branch. And the splanchnic mesoderm is the one that will give us the heart. Why? Because the heart doesn't really give you any sensations. But another word for splanchnic would be visceral, just in case they change it in the exam for some reason. Now, so this splanchnic mesoderm is going to give us this structure right here. This is what we call a heart tube. Our hearts didn't just spawn into our bodies. They started from something, then they became into what we know as our final human heart. So after the splanchnic mesoderm differentiates even more, we're gonna get this heart tube. And guys, this diagram pretty much summarizes the whole lecture. I want you to remember it very well. The heart tube is divided into 5 sections, from up until down. We start with the truncus arteriosus. Then we have the bulbus cordis. Then we have the ventricle. Then the atrium. Then the sinus venosus. Oh, don't worry, we will explain each one of them in detail in the same diagram in a couple of slides. But for now, let's set the foundations correctly. So the first body system that is functional is the cardiovascular system. The first organ that starts working in your body is the heart. When does it start working? In the 3rd week, or around 22 days. And as we said, it comes from the lateral mesoderm. And as we said, the lateral mesoderm is split into 2, the somatic mesoderm, which you can feel, and the splanchnic mesoderm, which is autonomic. You don't actively regulate it. And as we said, the heart tubes will derive from the splanchnic, not the somatic mesoderm. Another word for splanchnic here would be visceral, as the splanchnic mesoderm is supplied by the autonomic nervous system. Now let's go back to the diagram we just talked about. But before that, I want you guys to know the heart tube didn't suddenly become one tube. It was actually 2 different tubes. And these tubes formed together وصاروا one tube. All right, that's all I want you to know. They were two tubes, they fused to become one. And this is the final tube that we have here. I want you guys to remember the parts of the tube, which are the truncus arteriosus, bulbus cordis, ventricle, atrium, sinus venosus, and I also want you to remember what each one gives. Well, guys, don't worry. After every lecture, I literally have a summary table that's going to be all you need. But I prefer to explain the embryology itself because I felt like if I explain it, if I make it make sense for you, it's going to be easy for you guys to remember the tables and the high yield things for the exam. So I might go into some detail, but trust me, it's what you need to get a full mark on the embryology, inshallah. I'm not just hopeful that you guys get an A in embryology, لا, a full mark, not a single question wrong, inshallah. So let's start with the sinus venosus. The sinus venosus will have three branches. One is the common cardinal vein, the other is the vitelline vein, and the third is the umbilical vein. Now, the reason why the umbilical vein is in the color red is because it actually carries oxygenated blood and nutrients. You might be asking, if it's a vein, how is it carrying oxygenated blood? It's a vein, it should carry blood that is not oxygenated. Well, the thing is, technically you're right, but the umbilical vein is a special case because it's the vein that goes from the mother to the baby. Now we know that any blood vessel that goes away from the heart is called an artery, صح? And any vessel going towards the heart is called a vein. For the umbilical vein is going from the mother to the baby's heart to give the baby's heart some oxygen. So it is a vein because it goes towards the baby's heart. But it is oxygenated because the baby will need this oxygen and nutrients, of course. The common cardinal vein and the vitelline vein, they are deoxygenated, normal veins. Now let's go to the atrium. This atrium, or another name for it is atrium proper, it's going to give us the right atrium. Now you might be asking, what about the left atrium? Please remember this. The left atrium does not come from the heart tube. It develops from something completely different. We will talk about it later. The heart tube, the atrium part of the heart tube will only give us the right atrium. تمام? Now, فوقها, we have the ventricle. This ventricle will give us the left ventricle. You can even remember it لأنه it's very big. We know the biggest chamber of the heart is the left ventricle. So this ventricle origin will give us the left ventricle. Bulbus cordis. The bulbus cordis will give us إيش بعد left ventricle? The right ventricle. So it's called bulbous because it swells. And because it swells, the right ventricle will be at the sternal, costosternal surface. You guys know this. It's like the first thing in the costosternal surface. So that's why it's there, because of the bulbous cordis, because of the swelling. So the bulbous cordis will give us the right ventricle. Last but not least, truncus arteriosus. من اسمها artery. Arteriosus يعني artery. فit's gonna give us two arteries, the pulmonary artery and the aorta. تمام? The pulmonary artery and the aorta will both come from the truncus arteriosus. By the way, this was pretty much the whole lecture. Now we're just gonna go through some text and tables. وخلاص. So the endocardial tube, for those of you who like text, there will be two tubes. They will fuse to form one final tube, which will have five different parts. The truncus arteriosus, we're going from up to down now. The truncus arteriosus will give us the aorta and the pulmonary artery. Bulbus cordis, as we said, it swells, it gives us the right ventricle. The ventricle, it will give us the left ventricle, the bigger one. Atrium proper, or atrium, as you saw in the previous diagram, but sometimes they refer to it as the atrium proper. It will give you the right atrium. As we said, not the left atrium, the right atrium. Then we have the sinus venosus, which gives us three different branches: common cardinal vein, umbilical vein, and vitelline vein. You will later know in the umbilical vein, this very important vein that has oxygen for the baby, it has a left and right branch, or the right one will disappear. But don't worry about it now, we'll come back to it later. Now, there is something called the transverse sinus. So I'm sure you learned it in anatomy and in your lab. It's important for you to know how did it even form in the first place. The transverse sinus is basically a result of the apoptosis of the mesocardium. You don't have to go into detail what this apoptosis is, or how the mesocardium undergoes apoptosis, which is basically cell death. I just want you guys to know the transverse sinus comes after the apoptosis of the mesocardium. So the question would tell you which organ or part of the heart results from the apoptosis of the mesocardium, you would be like transverse sinus. Something I also want you to know, is the boundaries of the transverse sinus. Well, there aren't a lot. It's just anterior or posterior. Anterior to the transverse sinus, A for anterior, A for arteries. For anterior to the transverse sinus, we will have the arteries, which are the aorta and the pulmonary artery. Posterior to the transverse sinus, P doesn't stand for arteries, so we're going to have everything else, which are the right atrium and the superior vena cava. Please remember those relations. Now, let's talk about the sinus venosus in details, because even the three branches I talked about will give us some major arteries and veins, especially that you guys already know about. So let's agree into the sinus venosus. Again, it's made up of the common cardinal vein, the umbilical vein, the left one, obviously, the right one will disappear, and the vitelline vein. The common cardinal vein, شفتوا common cardinal vein? It will also divide. مو احنا in the body we have, for example, common iliac vein, which becomes internal, external iliac. We also have the common carotid, which becomes internal, external. حتى هنا we have the common cardinal vein. It will divide into anterior and posterior cardinal veins. Or each of these anterior and posterior veins will have left and right, because obviously in our body we have left and right. For the right anterior cardinal vein, now we said common cardinal vein, anterior, posterior. The anterior one will have left and right. The right one will give us the superior vena cava, which is important and easy to remember this because the superior vena cava is on the right side of the body. فأكيد is going to come from the right anterior cardinal vein. Now, focus with me for a moment. We have something called the left common cardinal vein or the left horn. This is not the left anterior cardinal vein. It's the left horn. It's completely different. Well, this will give us the coronary sinus. But you guys might be asking right now, if we have a right anterior cardinal vein that gives us the superior vena cava, but what about the left anterior cardinal vein? It actually disappears because you don't have two superior vena cavas in your body. You have one on the right side, one on the left side. So that's why the left anterior cardinal vein actually disappears, so that only one superior vena cava is found in the body. But let's say for some reason the left anterior cardinal vein stays in someone, which is obviously abnormal. Then you will have a second superior vena cava. I hope this concept is clear. For the right anterior cardinal vein, it's in the right, it will give you the superior vena cava. The left one, the left anterior cardinal vein, normally it disappears. But if it stays, we will have a second superior vena cava, which is obviously abnormal. As we said, the left horn or the left common cardinal vein will give us the coronary sinus. طيب, remember how we talked about the right atrium, how it comes from the atrium proper of the tube? Well, that was half of the story. The right atrium actually has two origins. One of them, which we already covered, which was the atrium of the heart tube. What about the other half? It actually comes from the sinus venosus. So the atrium will have a rough part and a smooth part. The rough part, the big part, the important part will come from the atrium proper, which is in the heart tube, logically. The smooth, minor part of the right atrium, which is posterior command, it will come from the right horn of the sinus venosus. Well, of course, right, because right atrium. So I hope this is clear. Obviously, I want you guys to remember and memorize all of this. Now, remember how we said the left atrium doesn't come from the heart tube? Yeah, it doesn't, because it actually is a result of the swelling of the pulmonary vein. For the pulmonary vein, it will swell, boom. That's how we have the left atrium. Now, let's talk about the bulbus cordus. We said in that it forms and stretches the right ventricle, it's less muscular than the left, because we know the left ventricle is the stronger one that pumps the majority of the blood. And as we said, the right ventricle forms the sternocostal surface. This is very important because a question could tell you which of the following forms the sternocostal surface of the heart. Is it bulbus cordus? Is it sinus venosus? Is it blah, blah, blah? For the question wouldn't tell you right ventricle, it would tell you the sternocostal surface. So just keep that in mind. Now let's talk about the bending of the heart. We know normally the heart is on the left. Why is it on the left? Because the heart will bend to the right, causing its apex to be on the left. That's why when we say our heart is on the left, we are referring to the big part of the heart, which is the apex. But how can this apex become to the left? But when the heart bends to the right, that's how the apex can go on to the left side. This is the normal. If the question tells you the heart is bending to the right, but the apex, which is what we care about, is bending to the left, خلاص, this is what we care about. Well, I know it might be confusing. You might be like, how is this normal? It's saying that the heart bends to the right. I agree with you, but here we don't care about the heart, we care about the apex of the heart. As long as the apex of the heart is towards the left, that's what matters. تمام؟ طيب, let's say if this was a complete opposite. If the heart bends toward the left, what will happen to the apex? It will be on the right side. Well, this is abnormal. It's called dextrocardia. So dextrocardia is when the heart bends to the left, causing the apex of the heart to be on the right side. طبعا dextrocardia, as you can see in this image, it simply means the heart's apex will be on the right. Well, it doesn't really have any functional abnormalities. يعني a lot of people can live normal lives with dextrocardia. Now let's talk about the interatrial septum. We said we have a right atrium and a left atrium, صح؟ بس يا أخي, these atria, they have to be divided because one has oxygenated blood, one has deoxygenated blood. How are they two different chambers if they're not divided? That's where we're going to explain this. The interatrial septum is a septum that divides the atria into two, left and right. We have two main components of this, the septum primum, which is the first one, and the septum secundum. Second for secundum, primum for prime, the first one. For the septum primum will form, then the septum secundum will form. These will be the two septa that will divide the atria. But if you guys notice, even though we have the septum primum and the septum secundum, there is the space between them, which still allows blood to cross through. We call this space a foramen ovale. Foramen is like an opening, like a window, تمام, which exists between the septum primum and the septum secundum. طيب, isn't it supposed to be closed? Because we don't want blood to go from the left atrium to the right atrium and vice versa. You're right. The moment a baby is born, the foramen ovale will close. And this could be asked in a question. As long as the baby is in his mother, the foramen ovale will be open. But the moment this baby is born, the moment he's born, this foramen ovale will close. But you might be wondering, how does it close? It closes because the septum primum will close on the septum secundum. The first septum, the prime one, the premium, will close on the second septum, اللي هو septum secundum. After the premium hits the septum secundum, خلاص, the foramen ovale closes and there is no longer any space for the blood to cross through. تمام? This process will cause the left atrial pressure to increase. The pressure in the left atrium will increase لأنه خلاص, the blood in it is not leaving anymore. So I want you to remember septum primum, septum secundum, a space between them, foramen ovale. The moment the baby is born, the septum primum will hit the septum secundum, causing the foramen ovale to be closed. And this will cause a rise in the left atrial pressure. Why? Because the blood will stay there. خلاص, it won't mix anymore. So as we said, two atria are divided by the septum primum and the septum secundum. طبعا the septum primum comes from the endocardial cushion. And this will allow blood flow from the right atrium to the left atrium. خلاص? Through the space, which we call the foramen ovale, between the two septums. Normally it stays open, as we said, until the baby is born. خلاص, it closes على طول. For the septum premium, as we said, it will hit against the septum secundum, and this will cause an increase in left atrial pressure. That's how the foramen ovale is closed. طيب, what about the ventricles? Isn't there a septum between them? There is. There is a septum. We call it the interventricular septum. Inter, between ventricles, ventricular, or septum. Well, the interventricular septum is made up of two parts, a big, huge muscular part and a small, tiny membranous part. But even though this membranous part is tiny, it can actually cause the most common heart defect. We call it ventricular septal defect. Makes sense. A defect in the septum separating the ventricles. It comes from an issue in the membranous part. I want you guys to remember, this is the most common embryological heart disease. If a question asks you, what is the most common embryological congenital heart disease? Ventricular septal defect. على طول. طيب, let's go to the truncus arteriosus. مو قلنا it divides into the aorta and the pulmonary arteries. طب how? It happens by something called the aorticopulmonary septum. Aorticopulmonary septum. This will divide the truncus arteriosus into the aorta and the pulmonary arteries. Let's say there is a problem in the aorticopulmonary septum, a problem that doesn't let the truncus arteriosus divide into aortopulmonary artery. What would be the result of this? A condition called transposition of the great vessels, where basically the aorta and the pulmonary arteries, they're going to be switched. Yeah, they're going to be connected to the opposite ventricles or atrias. You don't have to go into detail. I just want you to know if we have a problem in the truncus arteriosus, which division, which would mean a problem in the aortopulmonary septum, we will have transposition of the great vessels. طيب, what makes sure in the aortopulmonary septum works well, what doesn't have issues? Neural crest cells. The neural crest cells, they will ensure that the aortopulmonary septum is in the middle, it's working well. If we have a defect in this neural crest cells, هتصير مشكلة بالaortopulmonary septum, the septum will be on the right side. This will cause the aorta to become bigger, causing something that we call overriding of the aorta. All I want you to know here is that the neural crest cells are important for the aortopulmonary septum. If something called goes wrong, this will lead to overriding of the aorta, which can be seen in a condition called tetralogy of Fallot. Let's talk about tetralogy of Fallot. I also like to call it tetralogy of Fallot, just gives it a more prestigious name. For tetralogy of Fallot, basically it's an embryological condition which will present with the same four signs or problems every single time. Pulmonary stenosis, right ventricular hypertrophy, overriding aorta, like we just said, and ventricular septal defect. I just want you to know, these four are in tetralogy of Fallot. It's Fallot, guys, but I just like to say it Fallot. فرemember إن these four problems happen in tetralogy of Fallot. طيب, what else do I want you to know? I want you to know إنه any baby with this condition will present with cyanosis. What is cyanosis? It's basically when we don't have enough oxygen, for the baby's skin and hands will be bluish. Bluish because of the deoxygenated blood. That's what cyanosis is. If you get a case, a baby has cyanosis, tetralogy of Fallot على طول. طيب, with this ventricular septal defect, overriding of the aorta, all of these issues of the aorticopulmonary septum, as we just talked about, they come from the neural crest cells. تمام? طيب, this is a summary table of everything we talked about in the lecture. After you understand everything I explained about this lecture, you just come to this table, memorize it, or most of the questions will come from it. As we said, lateral splanchnic mesoderm gives us the heart tubes, truncus arteriosus, aorta pulmonary artery, bulbus cordus, right ventricle, ventricle, left ventricle, atrium proper will give us the rough anterior right atrium, while the right horn of the sinus venosus gives us the smooth posterior right atrium. عندنا right anterior cardinal vein, as we said, it's on the right, it's anterior, it's going to give us the superior vena cava, while the left anterior cardinal vein, إيش قلنا? Let's go back. The left anterior cardinal vein, it disappears. Or if it's still there, we're going to have two superior vena cavas. Remember this, it's very important. Right, let's go back. Then we have the left common cardinal vein, or the left horn. It gives us the coronary sinus. Then, when the pulmonary vein swells, we will have the left atrium, and last but not least, apoptosis of the mesocardium, it will give us the transverse sinus. وكذا نكون خلصنا the first two lectures out of 7. Obviously, للأسف, I can't hear your voices or have your questions in chat today. ولكن, obviously, if you have any questions, let me know. Contact me anytime. But for now, I have questions for you. I'm gonna read them and say the answer quickly because I'm assuming you will pause the video to answer. Which of the following forms the smooth, not the rough, the smooth part of the right atrium? As we said, it's the sinus venosus, more specifically, the right horn of the sinus venosus. A 3-year-old boy has a heart that bends to the left. For the heart is bending to the left, but the apex is toward the right. What is the condition? Dextrocardia, because what we care about is the apex of the heart. The apex of the heart should be on the left, but if the apex of the heart is on the right, this is how we have dextrocardia. طيب, what is the most common heart defect? We said it, ventricular septal defect. What is the reason for the apex of the heart to be directed to the left side? And why is the apex directed to the left side? The reason why is because the embryonic heart, as we said, it bends to the right. For the apex هيصير on the left. صح? Obviously, the bulbous cordus swells. This is not what we care about. We care about in the heart bends to the right, causing the apex to be on the left. طيب, what will the persistence of the left anterior cardinal vein give rise to? We said it, a double superior vena cava. طيب, last question. In tetralogy of Fallot, which of the following causes the defect in aorticopulmonary septum? The answer here would be defect in neural crest migration. We said The question is asking you, it's not asking you what is the result of a defect in the aorticopulmonary septum. If it's asking you of the result, كان قلنا overriding of the aorta, حتى ventricular septal defect, all of these are correct. But here they're asking you what causes the defect of the aorticopulmonary septum in the first place. So that's why the answer would be neural crest cells, a defect in them يعني. طيب, now we're going to talk about the aortic arches. The aortic arches are basically structures or arches that give rise to certain structures. I just want you to remember what each arch gives rise to. تمام? But I'm trying to make this as simple as possible so that you guys can memorize them easily. تمام? These are the aortic arches. The heart would be here. The heart would be here, next to the truncus arteriosus, next to the aorta or pulmonary artery. فبecause the heart is in this position, it's so far from the first and second arches. That's why both of them will disappear. خلاص, first and second arch, don't worry about them again. They always disappear, left and right. So we start from the third arch. The third aortic arch will give us the common carotid artery. تمام? Both of them, the left and the right aortic arches, will give us the common carotid artery. Now let's move on to the fourth aortic arch. This is very important because the right and the left are different. The right fourth aortic arch will give us the right subclavian. Easy, صح? Because it's on the right. Now you may be assuming that the left aortic arch will give the left subclavian, but no. The left subclavian will come from somewhere completely different. We will talk about it later. صح, left atrium came from somewhere else. Even the left subclavian will come from somewhere else. هما كده, everything on the left, they just like to do things on their own. The left fourth aortic arch will give us the arch of the aorta. Now, this might be confusing. The aortic arch gives us the arch of the aorta. There are two different things. These are called arches of the aorta. They are embryological structures. They are simple arches that give us other, let's say, branches. The arch of the aorta is only one thing. You know it, guys. When the aorta basically arches to go down, that's the arch of the aorta. For the left aortic arch will give us the arch of the aorta. Please distinguish between those two things. The aortic arches are simply the embryological origins, while the arch of the aorta is the one bending of the aorta. طيب, lucky for you, the fifth aortic arch disappears. For 1, 2, they're far away from the heart, they disappear. Number 5, كده يعني, it wants to disappear as well. يعني, for some reason. Now let's move on to the sixth aortic arch. With this one, كمان, it's very important because not only do we have right and left, but we also have proximal and distal. So the proximal right sixth aortic arch will give us the right pulmonary artery proximally. Or the left proximal sixth aortic arch will give us the left pulmonary artery. But distally, the left sixth aortic arch will give us the ductus arteriosus. We will talk about what it is in a moment. But the right distal sixth aortic arch disappears. Now, I know this might be a bit confusing. We're going to go through them again. But just to recap the sixth aortic arch, the sixth aortic arch has proximal or distal. Each of the proximal and distal will have right and left. For proximally, both of them will give the pulmonary artery. Right proximal for right pulmonary artery, left proximal for left pulmonary artery. Distally, only the left will give us something, which will give us the ductus arteriosus. The right distal sixth aortic arch will disappear. You have to remember this, guys, and memorize it. Every arch, what does it give? Even the details, proximal, distal, left, and right. تمام? Now, let's summarize for those of you who like text. We have 6 pairs, as we said, of aortic arches on either side, left and right. And they give rise to different structures. These aortic arches are developed from the aortic sac. It's just where the arches come from. The formation of the aortic arches is controlled by neural crest cells. So if we have a problem in the neural crest cells, the aortic arches won't be able to differentiate properly. Now, as we said, arches 1, 2, and 5, they disappear immediately. The only ones that remain are 3, 4, 6. 3 is very easy. It gives us the common carotid. 4, it has left and right. The left, as we said, will give us the arch of the aorta. With the right, obviously, the right aortic arch will give us the right subclavian artery. تمام? Arch number 6, we have proximal and distal. As we said, the left proximal arch 6 will give us the left pulmonary artery. The right proximal arch 6 will give us the right pulmonary artery. But distally is where the difference is. The left distal arch 6 will give us the ductus arteriosus, while the right distal arch 6 disappears, doesn't give us anything. Now, there is an important concept you guys need to know. The left recurrent laryngeal nerve, it is lower than the right recurrent laryngeal nerve. ليش؟ لأنه the left recurrent laryngeal nerves, as it's trying to go up, it will find the ductus arteriosus. مو احنا قلنا on the left side, the left arch, the left sixth aortic arch will give us the ductus arteriosus. طيب, for the ductus arteriosus, it's going to be on the left side. For this recurrent laryngeal nerve, when it's going up, it's going to find the left, sorry, it's gonna find the ductus arteriosus on the left side, which is going to wrap around it. But on the right side, the right recurrent laryngeal nerve, it's going to keep going up. There won't be a ductus arteriosus. ليش؟ لأنه it disappears the arch 6 on the right distal side. For the right recurrent laryngeal nerve will keep going up until it hits the right subclavian. What do I want you to know in this? I want you to know in the left recurrent laryngeal nerve hangs on the ductus arteriosus, right recurrent laryngeal nerve hangs on the right subclavian. Now, just for your knowledge, this was never really asked about before. We said the right subclavian comes from the right fourth aortic arch. But what about the left subclavian artery? It comes from something we call as the seventh intersegmental artery. Something mal abu dakhal with what we're talking about. I just put it there to feed your curiosity. Now, can we have two aortas or two arches of aortas? Yeah. Didn't we say in the left aortic arch will give us the arch of the aorta? But what if the right fourth aortic arch gives us an arch of the aorta? We will have two arches. Well, this is abnormal, obviously. Now, how does this happen? The fourth right aortic arch, it usually gives us the subclavian artery. But what if the dorsal part of this fourth aortic arch on the right persists and stays? That's how another arch of the aorta will be present, which would cause the compression of the trachea and the esophagus because they're found on the right side. But I just want you to know and the fourth aortic arch قلنا فيه left and right. Left gives us the arch of the aorta, right gives us this right subclavian artery. If the right also tries to give us an arch of the aorta, we will have this double aorta. Summary. This is the summary slide. We said arch 1, arch 2 disappear completely. Arch 3, common carotid artery. 4 left, arch of aorta. 4 right, right subclavian artery. 5 disappears, و6 عندنا proximal ودistal. Proximal left pulmonary artery, right proximal right pulmonary artery. Distally, only the left sixth aortic arch will give us something, which will give us the ductus arteriosus. The right sixth distal aortic arch will disappear. Another checkpoint. Now we're done with this lecture as well. And this is the first practice question. The rightly recurrent laryngeal nerve hooks around the right subclavian artery. What is the embryological basis for this nerve placement? The answer would be the distal part of the sixth aortic arch will disappear on the right side. فما عندنا ductus arteriosus on the right side, but that's why the recurrent laryngeal nerve will go to the right subclavian artery. Obviously, the left recurrent laryngeal nerve, as we said, it will go where? To the ductus arteriosus because it's present. Next question. What explains the presence of a double aortic arch? As we said, persistence of the fourth right distal aorta. If the fourth arch on the right side not only gives us the right subclavian, but also an arch of the aorta, we will have a double aortic arch. طيب, last question for this lecture. The proximal part of the left sixth aortic arch will come from where? Left pulmonary artery. This is a very recall question. قلنا the sixth aortic arch, proximal distal. Proximals will give us, if it's left proximal, left pulmonary artery, right proximal, right pulmonary artery. Yeah, honestly, this table is all what you need. I'm gonna get me some water, then we're gonna continue the easier half of this lecture. طيب, now we're gonna talk about the embryology of the respiratory system. خلاص, we finished from the cardiovascular system. Now we have the respiratory system. As we started in the beginning of the lecture, we want to go back to the germ layers. We said, the heart comes from the mesoderm. Now, the esophagus, trachea, lungs, these inner organs that are considered linings, they come from the endoderm. For the star of the show right now is going to be the endoderm. Tamam? Something else I want you to know. There is something very important that stimulates the development of the lungs. It's called amniotic fluid. This amniotic fluid has to be in the lungs because it's going to help the lungs grow. Like, into you guys know, how does anything get to the lungs? From the trachea. طيب, how does this amniotic fluid make sure that it doesn't go to the esophagus instead? How can we ensure that this amniotic fluid goes to the trachea to reach the lungs? It's through the tracheoesophageal septum. The tracheoesophageal septum, from its name, tracheo and esophagus, tracheoesophageal septum. It's basically a connection between the trachea and the esophagus. And it's very normal when the baby is still growing and developing, and his mother, obviously. It's very normal because this connection will ensure that all the amniotic fluid goes to the lungs. Now, obviously, now that we're out of our mother's wombs, this connection is no longer there. But there is a condition that causes babies to be born and still have the tracheoesophageal septum. We call this condition as tracheoesophageal fistula. A fistula would be abnormal. تمام? For those of you who like text, the respiratory organs begin to form during the fourth week, more third week, like the heart. Amniotic fluid is what simulates the formation of the lungs. In the fourth week, there has to be some connection between the esophagus and the trachea. Why? Because we want to allow the amniotic fluid to reach the lungs, to help the expansion of the lungs. Without this connection, fluid will only go to the stomach, على طول على esophagus. For this connection, this normal connection is called tracheoesophageal diverticulum or septum. Both of them are the same thing. طيب, now I want you guys to get introduced to two terms we're going to use a lot. Oligohydramnios and polyhydramnios. Poly من اسمها, poly, a lot. Polyhydramnios means we have a lot of amniotic fluid. That's abnormal and we have too much. Oligohydramnios means we have little amniotic fluid, less than normal. طبعا if we don't have a lot of amniotic fluid, there will be a retardation of the lung development because we need this amniotic fluid, صح? Keep this in mind. Now, let's say a baby is born and the baby drinks milk, gets a choking sensation. What does this mean? It means the milk is going to the trachea. Why? Because the connection is still there. The tracheoesophageal diverticulum, it's still there. They didn't separate. Well, this condition would be called tracheoesophageal fistula, as I said. Well, this will lead to polyhydramnios. The connection is still there. For even after the baby is born, all the fluid is going to the lungs. So that's why it's going to be polyhydramnios. Now, a very simple concept, never tested on before low-key, but I put it for the sake of completion, intraembryonic coelom. What is the intraembryonic coelom? It's basically a space. It's a space that comes from the mesoderm which allows the lungs to grow. Intraembryonic coelom is simply a space that allows the lungs to grow and expand. That's all you need to know. طبعا, you guys took an anatomy in that the lungs have a parietal layer and a visceral layer. The visceral layer is very close to the lungs, صح? فموst likely you wouldn't feel it at all. فإت's the visceral layer, the splanchnic layer, the autonomic layer, لأنه it's visceral, it's close to the organ. The parietal layer of the lung actually receives somatic innervation. I want you to make this, let's say, distinction. The visceral layer of the lung will receive autonomic or splanchnic innervation, while the parietal layer of the lung that is on the outside will receive somatic innervation. طيب, let's move on to this very important concept. I just want you to know that the development of the lungs happens through phases, and I'll tell you what I want you to know about these phases. First of all, let's agree on what the phases are. We have a pseudo-glandular phase, a canalicular phase, a saccular phase. This is the most important phase because it's where many stuff happen. We will talk about it in a bit. Ossacular comes from sac. Or there is another name for this phase, which is the terminal sac phase. The terminal sac phase, saccular phase, same thing. Last but not least, alveolar um, phase. For the saccular phase is important is because it's in this phase where we finally have surfactant. With this surfactant, once it happens, this is basically where the baby is able to live outside the mother's womb. تمام. It's at this stage, the saccular stage, where the baby is able to live outside his mother خلاص without depending on her oxygen. For those of you who like text, pseudoglandular stage, tissue is still not fully grown. It just started. You don't need to know this, just for you to understand. Then we have the canalicular stage, when it's not canal, every tube has a canal. Terminal sac stage, the saccular stage, that's where the surfactant is produced. Where the surfactant is very important because it's what's going to allow the baby to breathe, basically. Oh, that's what we call fetal viability. Baby can survive outside the womb. Last but not least, the alveolar stage. Something I want you to remember. I want you to remember the weeks. Yani, if the question asks you about pseudoglandular stage, you would choose 6 to 16. Canalicular, 16 to 26. Terminal sac stage, the key and magic number, 26. Usually it comes as 26 to 28, كده. That would be the terminal sac stage. The question would be like, during which weeks can the baby survive outside the womb? You would link it, when can it survive outside the womb? In the terminal sac stage. Why? Because we have the surfactant. When is the surfactant produced? In the terminal sac stage, which is between 26 weeks, minimum 26 weeks, and usually until 28 weeks or until birth. Alveolar stage, just for the sake of you knowing, 32 weeks until 8 years. طيب, now let's talk about every problem and what it's going to cause. If we have oligohydramnios, which is little amniotic fluid, I said this before, we're going to have lung development retardation. ليش؟ لأنه we don't have enough amniotic fluid. Well, the amniotic fluid is what's going to allow this lung to grow. If we don't have this amniotic fluid, how is the lung going to grow? Something else, congenital diaphragmatic hernia. I'm going to talk to you about what this condition is in a moment, but I just want you to know, in a person with congenital diaphragmatic hernia, we're going to have agenesis of the lungs. The lungs will basically not form muscle. طيب, what if we have esophageal atresia? Esophageal atresia means the esophagus isn't formed. Atresia means something doesn't form. In this case, we will have polyhydramnios. Why? It makes sense. If we don't have an esophagus, everything, all the amniotic fluid or any fluid will go to the trachea, which means it will end up in the lung, which will cause an excess of fluid, which is polyhydramnios. طيب, let's say a baby died from stillbirth, which is basically dying before the process of giving birth. What would we see in the lungs? We would see it would sink in water. ليش؟ لأنه before the baby is born, the lungs still didn't activate, but there is still not any air inside of the lungs. If we take the lungs of a person, a baby obviously, put them in water, and the lungs sink, this means the lung is full of liquid. It means there is no air, but it means the baby died of a stillbirth. It didn't have the chance to be born yet. I just want you to know stillbirth is associated with lungs sinking in water. That's it. Just remember the associations here. طيب, now we're going to talk about the embryology of the diaphragm. The diaphragm has two main components, the central tendon and the mesentery. The mesentery is what's going to wrap around the esophagus, the aorta, the IVC, the things that basically are in the diaphragm or pass through it. The central tendon, which is in the dead middle, it's the white muscle. The central tendon is the muscle, which makes up two-thirds of the diaphragm, while the mesentery, the other part, it will only make up one-third of the diaphragm. So for those of you who like text, the diaphragm has two parts, mesentery and the central tendon. The mesentery, it is a splanchnic structure. It's not a muscle, it's a splanchnic structure. You don't even feel it, which covers the structures that pass through the diaphragm. For example, the inferior vena cava. The central tendon, it is the muscle, and it makes up two-thirds of the diaphragm. طيب, you guys know, I think, from anatomy, and the diaphragm is supplied by the phrenic nerve, but the phrenic nerve is C3, C4, C5. How is a cervical nerve reaching the diaphragm and supplying it? It happens through what we call a myotome. A myotome is basically an area of a body that is tasked to be innervated by a certain خلينا نقول nerve. تمام؟ فthe myotome in the diaphragm is supplied by the C3, C4, C5, which are the phrenic nerves. Just know there are myotomes that help the phrenic nerve innervate the diaphragm. Now, four different components, four different stages, four different parts are what? are going to give us a diaphragm in the end, are what are going to give us the central tendon and the mesentery. Well, I want you to remember all four of them. The septum transversum. The septum transversum is the first one. It means it's the most important one. Like the most important origin will give us the most important part of the diaphragm. What is the most important part of the diaphragm? It's the central tendon. Why is it the most important part? Because it makes up two-thirds of the diaphragm. Then the mesentery of the esophagus. The mesentery of the esophagus من اسمها mesentery, فit's going to give us the mesentery of the diaphragm. Then we have pleuroperitoneal folds. Pleuroperitoneal. There are pleuroperitoneal folds and membranes. تمام? Well, these membranes will later become replaced by a muscular ingrowth. Well, there is going to be an issue that we're going to talk about that causes the membranes to not become a muscular ingrowth. Well, this is the congenital diaphragmatic hernia that we talked about just previously. In the previous section, we said it causes agenesis of the lungs. طيب, let's go to the sources of the diaphragm. As we said, four sources. Septum transversum gives us the central tendon, تمام, supplied by the phrenic nerve. Mesentery of the esophagus, it gives us the membrane or the crura, or another name for it, which covers the IVC, esophagus, وهالأشياء, which basically is the mesentery. تمام? Then we have the pleuroperitoneal fold, which is a membranous structure as first. We said it's a membranous structure, which will be replaced by a body wall. تمام? طيب, now we have three segments. What is the fourth section of the diaphragm? The muscular ingrowth. So we have the pleuroperitoneal fold, which will give us the body wall. This body wall, with this membrane, it has to become a muscle. If it doesn't become a muscle, we're going to have congenital diaphragmatic hernia. A congenital diaphragmatic hernia happens when the body wall is not replaced by a muscular ingrowth. For this will cause the diaphragm to be weak. And we don't have the muscle, we still have the membrane. For because the diaphragm is now weak, structures can bulge through it. Well, there is one structure I want you to know that herniates, it is the stomach. تمام? I'm going to repeat this just to make sure it's clear. The diaphragm comes from four different things. The septum transversum gives us the central tendon. The mesentery of the esophagus gives us the mesentery. The pleuroperitoneal folds and membranes will give us the body wall. تمام? With this body wall, with this membrane, it will change into a muscular structure. If this change from body wall into muscular structure is impaired, it doesn't happen properly, we're going to have congenital diaphragmatic hernia, which, as we said a few slides earlier, is associated with agenesis of the lungs. طيب, right now we finished the fifth lecture, fourth and fifth lecture, so that's 5 out of 7. Let's move on to the practice questions. Wallah, Loki, I miss hearing your answers and interacting with you. Inshallah, the next session would be a live one. But maybe in this case, it's better for you that it's recorded because it means I'm going to finish fast, inshallah. Well, again, if you have any questions, never hesitate to contact me. Which of the following is caused by oligohydramnios? We said lung hypoplasia. The lung will not grow. Hypoplasia means hypo means less, plasia means proliferation. So we will have less proliferation of the lung. تمام? The trachea is lined with pseudostratified columnar ciliated epithelium, blah blah blah, with goblet cells. What is the origin of this epithelium? خلاص, the moment you see trachea, endoderm. We said trachea, esophagus, lungs, they come from the endoderm. A neonate presented with increased saliva and mucus around his mouth. When the doctor tried to pass a catheter toward the stomach, he wasn't able to reach it. Which of the following problems does this child have? Esophageal atresia. Why does this patient or child has esophageal atresia? Because the doctor tried to put a catheter to the stomach, but he couldn't reach the stomach. But what is the thing that helps us reach the stomach? It's the esophagus. If you can't reach the stomach, it means we don't have an esophagus. That's why the condition here is esophageal atresia. طيب, during which weeks of development is the baby able to survive outside the womb, which is the terminal sac stage? We said 26 to 28 weeks. طيب, let's move on to the final section of this PAL session, fetal circulation. Very easy, will be done in no time, inshallah. I want you guys to know, during, let's say, the embryonic phase of a baby's growth, there are three temporary structures that are important in the arterial and venous system, in the fetal circulation, let's say. Why are they important? Because they make the transport of oxygen to the heart easier. For example, we have the umbilical vein. Why is it important? لأنه the umbilical vein it's going to take the oxygenated blood على طول على heart. It's going to skip the liver. Because in a normal human, the drainage of the blood, you're going to pass through all the organs of the body, from up to down or down to up. But in a baby, we want all this oxygen to go immediately to the heart. And that's where we have something like the umbilical vein. تمام? With the ductus arteriosus. Do you guys remember the ductus arteriosus? It's a structure we talked about. It's originated from the um, fourth, the sixth distal left aortic arch. The left distal sixth aortic arch gives us the ductus arteriosus. Notice how there's only one. There isn't one on the right. بس في ductus arteriosus واحد. As we said, the left recurrent laryngeal nerve will hang on to the left ductus arteriosus, but the right recurrent laryngeal nerve will hang on to the right subclavian artery. ليش؟ لأنه there isn't a ductus arteriosus. Last but not least, we have the ductus venosus. These are the three structures that bypass certain things in the baby to better, let's say, to improve the oxygen transport. طبعا now, after we've been given birth to, after we have grown up, these structures aren't there anymore. What happens? The umbilical vein will turn into something that's still found in us. It's called the ligamentum teres, while the ductus venosus will become something called the ligamentum venosum. Don't worry about the ductus arteriosus. Those two are what matter. تمام? طبعا something important to know, we said it earlier, and only the left umbilical vein will stay. Well, notice how يعني, we only have one branch of it. The right umbilical vein, it disappears. طيب, so for those of you who like texts, we have three structures that have a bypass mechanism to get to the heart: foramen ovale, ductus arteriosus, ductus venosus. Well, obviously, the umbilical vein is also one of them. If you get an SAQ saying name three, let's say, structures that bypass certain structures to get to the heart immediately, you can say any of the four: foramen ovale, ductus arteriosus, ductus venosus, umbilical vein, اللي يعجبكم. The liver takes up so much oxygen. Guys, the liver is one of the biggest organs in the body. So that's why in the fetal period, we want to bypass it. يا أخي, we need this oxygen for the heart now. ما عندنا وقت for the liver. So that's why the left umbilical vein will skip. It will bypass the liver to get to the heart immediately. تمام? Remember this, very important. Now remember the vitelline veins, which were branches of the sinus venosus. These vitelline veins, they will come together, or they will give us something called the portal vein. This is all I want you to know. As we said, the left umbilical vein is what carries oxygen and nutrients from mother to baby. The right one disappears. طيب, I think you guys know this from anatomy. The superior vena cava is made up of the right brachiocephalic and the left brachiocephalic veins, صح? طيب, we want to talk about the origin of the left brachiocephalic vein. But before that, let's go a step back. Do you guys remember من زمان how we said إنه we have common cardinal veins which give us anterior cardinal or posterior? طيب, the anterior ones في عندنا left or right. The right anterior vein and the left anterior cardinal vein, they will come together to become the anterior communicating vein. It's just a connection between the two. Left anterior cardinal, right anterior cardinal, give us anterior communicating. That's what I want you to know. Well, I want you to know, in this anterior communicating vein is what will give us the left brachiocephalic vein. But I just want you to know, in the origin of the left brachiocephalic vein is the anterior communicating vein. What gives us the anterior communicating vein? The left and right anterior cardinal veins. طيب, let's talk about how the inferior vena cava comes. لأنه إحنا we know how the superior vena cava comes. طب what about the inferior vena cava? It comes from four different segments, which I want you guys to know and remember. Something easy. Anastomosis between the sub and suprarenal veins. خلاص, it's just anastomosis of certain vessels. Then we have a small portion of the posterior cardinal vein. Do you guys remember إنه عندنا anterior cardinal؟ طيب إيش فائدة ال posterior cardinal؟ فائدته إنه it gives us the inferior vena cava. Then we have a prerenal segment and a postrenal segment. The prerenal segment, we call it subcardinal vein. With the postrenal segment, we call it supracardinal vein. For now, I just want you to get familiar with these. تمام? For four things make up the inferior vena cava, or inferior vena cava, whatever he says, as the sub-supraanastomosis, the prerenal segment, which is the subcardinal vein, the postrenal segment, which is the supracardinal vein, and last but not least, the posterior cardinal vein. So as we said, these are the four portions which make up the inferior vena cava. But one thing which is very important, I want you to know it. شفتوا the post-renal right supracardinal vein? احنا we know in the superior vena cava, inferior vena cava, they're always in on the right side. By the way, guys, never come to the PO office. These mosquitoes يعني, have been bothering me the whole session. Anyways, ف the superior and inferior vena cava, they're on the right side, صح؟ ف Obviously, only the right خلينا نقول supracardinal vein is the one that should be there because it's what's going to give us the inferior vena cava. طب let's say a left supracardinal vein is there. What is going to happen? We're going to have a double inferior vena cava. زي ما كان عندنا a case of double aorta, a case of double superior vena cava, we also have a case of double inferior vena cava. تمام? So please remember the four things that give us the inferior vena cava. Remember this, very important. If we have a left supracardinal post-renal vein, we're gonna have two IVCs. This is a summary of everything in this lecture. قلنا the vitelline veins, they come together to give us the portal vein. Left and right anterior cardinal veins will give us the anterior communicating vein. Anterior communicating vein, which is the two together, the two cardinal veins together, it will give us the left brachiocephalic vein. Last but not least, these four اللي هم posterior cardinal vein, postrenal supracardinal vein, sub-supra-anastomosing vein, and prerenal subcardinal vein, they will give us the inferior vena cava. Trick question, which of those four, if the left version of it was there, would give us a double inferior vena cava? It's this one, the post-renal right supracardinal vein. If we have a left one, we would have a double inferior vena cava. And with that, we finished 7 out of 7 lectures. You might be asking, what about the last lecture, the review, the clinical review embryology? I integrated it in the other slides, don't worry. As I said in the beginning, this past session is genuinely all you need. 60 slides, 20 of them are checkpoints or practice questions. This is all you need for your final of CVP, inshallah. Whether you're watching this year, next year, or whenever you're watching it. Let's move on to the last few questions before we conclude. The left brachiocephalic vein is larger than the right one. As it comes from which of the following structures? It's asking you basically what is the origin of the left brachiocephalic vein. We would say anterior communicating vein, as we previously agreed on. Which vein bypasses the liver to reach the heart during fetal life? We said it. This vein wants to give oxygen and nutrients to the heart, so it skips the liver. This would be the left umbilical vein. Which of the following will cause double inferior vena cava? We just said it. Presence of the left postrenal part of the supracardinal vein. Don't be tricked. Presence of the right postrenal part of the supracardinal vein is normal. My IVC is on the right side, so we need to have the right supracardinal vein. What's abnormal is having one on the left side. All right? طيب. Let's move on. Oops. Seems like I put the same question twice by accident. But anyways, that was it. That was the embryology. I wouldn't even call it a crash course because I didn't really crash anything. This is genuinely everything you need to know. Everything you need to know about embryology for CVP was in this past session. MashaAllah, ما طولنا كثير. This hour and a half is more than enough for you. Best of luck on CVP. Genuinely, guys, embryology, free questions, free marks. Especially if you watch this past session over and over to make sure you memorize everything. خلاص, this is all you need, inshallah, for embryology. And I wish you the best of luck. CVP was genuinely a beautiful block. It was my personal favorite in first year and maybe until now. So enjoy it, enjoy the exam. Don't worry about embryology anymore. Focus on the more important stuff like physiology. And thank you guys so much. Obviously, feel free to contact me anytime you would like. This is my phone number. Any questions you have, any concerns, anything ever, never hesitate to reach out. And please, if you have the time, scan this QR code. Give us your honest feedback. Yani we can always improve the PAL sessions, whether it's mine or someone else. There's always room for improvement. Other than that, يعطيكم ألف عافية. Thank you guys so much. And best of luck on your exam. I wish you nothing but the best.